Support for this podcast is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. Have you heard the latest news from Vabysmo? There's even more to see with 4 years of long-term data. Explore the RONEX open-label extension data at vabysmo-hcp.com. That's VABYSMO-HCP.com. Start first with Vabysmo.
Welcome to the new Retina Radio Journal Club of Vit Buckle Society. My name is Dr. Barton Blackorby from the Retina Institute in St. Louis, and I'm joined today by Dr. Hong-Uyen Hua from Bascom-Palmer. Welcome, Dr. Hua.
Hi, thanks for having me.
And Dr. Louis Cai from the Retinal Diagnostics Center in San Jose. How's it going, Dr. Cai?
Happy to be here. Thank you for having me.
Today, we'll be discussing a paper titled Photobiomodulation for Age-Related Macular Degeneration, authored by Srinivas Sada, and was published online in the Viewpoint section of the JAMA Ophthalmology journal in January 2025. Dr. Hua, now that we've set the stage for our discussion, could you take a moment to summarize the key findings of this article for us?
Absolutely. This is a Viewpoint section article written by Dr. Srinivas Sada, which is a summary and critique of the phase 3 LIGHTSITE trial, which includes a hint of 24-month data as well. So photobiomodulation was FDA approved for treatment of dry age-related macular degeneration on November 4th, 2024, and the device that was approved was Lumathera's Velita light delivery system. And so this system was designed to treat non-neovascular or dry age-related macular degeneration. The therapy involves application of visible to near infrared light to eyes over multiple sessions. These sessions were done about every 4 months, and they last several minutes, performed in office, and there was about 5 to 9 sessions given. The theory on the mechanism of action was that the specific level of light stimulates mitochondria and improves metabolic function of retinal cells and increases ATP production. Right now, this device is already approved in Europe by CE mark based on a few small studies. And this study specifically in the US for the FDA approval was a double-masked sham-controlled study. The inclusion criteria include dry age-related macular degeneration with the presence of drusen and non-foveal center geographic atrophy, and they excluded eyes with a history of choroidal neovascularization, center involving geographic atrophy, and other retinal diseases. The number of eyes included in the study were 148 eyes in 100 patients. The patients were randomized, 54 eyes were assigned to sham, and 91 eyes were assigned to photobiomodulation. And the primary endpoint at 13 months was met. So the patients in the treatment arm, the photobiomodulation arm, was 5.4 letters, and the mean gain in the sham arm was 3 letters, which was statistically significant. The p-value was 0.02 in terms of the vision gain in the photobiomodulation arm. So it's important to note here that the sham arm was actually an active control arm, because if the sham arm did not show light to the patients, they would know that they weren't receiving the treatment. So these patients received 100-fold decreased fluence of light, the yellow and the red light in this arm. And so the month 24 data was publicly presented and included in this viewpoint as well, in which the mean increase of 5.9 letters in the photobiomodulation group and 1.0 letters was gained in the sham group. But in this data, the number of participant dropout was not available. A few possible shortcomings of the study include the dropout rate at 13 months. It's about 23.5% in the sham arm and the 14.1% in the treatment arm, the photobiomodulation arm. And it's unclear when these patients dropped out. And there's some issues with protocol clarity as well. We don't know if these patients were dilated when they received the treatment, were they monitored during the treatment sessions to ensure compliance. In an earlier article, the eyes were open for 2 phases and closed for 2 phases of treatment. So it bears to mind with patients that had 1 sham eye and 1 treatment eye, the sham eyes receive this light dosage. And so some baseline concerns include in the sham patients, On average, the baseline age of the sham patients was older, so 77 years old versus 74 years old. And so that's important in age-related disease and baseline vision. 30% of patients had worse than 20/40 at baseline, and the entire population had a mean 20/40 at baseline, which is interesting because if the patients had intermediate or early dry AMD, we would expect that their visual acuity should be around 20/25. Given that 70% of these eyes were within 5 letters of 20/32, a change within 5 letters may represent a placebo effect or a regression to the mean. And then at 24 months, the mean increase of 5.9 letters in the photobiomodulation group and 1 letter seemed promising, but dropout rates were unavailable, as I discussed before. So in conclusion, we have a new therapy that's available for these patients with dry, early or intermediate non-neovascular AMD, but given the small sample size and unclear study protocol, other issues as well, we are unable to draw definitive conclusions about the safety and efficacy from LIGHTSITE III at this time.
Yeah, fantastic summary, Dr. Hua. I like this article because it shows us data from a new trial on a new therapy, but then an expert opinion from someone within our field. So, Dr. Cai, I'll kind of throw this to you here. How do you navigate these situations where you have, data that's presented, but then someone in the field that's also, either published or maybe within your own practice that's given you, another viewpoint on this? What are your thoughts on that?
I think it's always good to see new treatments being tried, especially in an area like dry AMD. So far, AREDS2 vitamins have been what we've been recommending mostly for this population of patients. Just to give a little bit of context about photobiomodulation before getting back to your question, it has been used in other conditions like diabetic retinopathy, myopia, and also in different specialties like in wound healing, Alzheimer's disease. And so it's not necessarily a new technology, but the application for it is quite interesting. It's just like we hear things often secondhand, and in our field, we often need to hear things from other people, our peers, before we truly adopt a new technology. It's always good to hear a almost like a second opinion from someone who's unbiased, and having a commentary and editorial is very useful in order to get some unbiased feedback and context regarding the new treatment.
I agree. Dr. Hua, what's your thoughts on that?
Yeah, I think going into the nuance and giving critique and also clinical relevance to the study is really important and really useful, because sometimes with all of the data, applying it to real world scenarios and the practicality of the treatment as well, all of that context is really useful.
Well, that concludes our overview of the photobiomodulation article. Let's take a short break, and when we return, we'll dive deeper into the study's methodology, science details behind its approval, and its real-world clinical implications. Stay with us, we have a lot more to explore.
ENCELTO. Incelto Revokenogene Teveretso Louis, a new FDA-approved treatment that may be right for your patients. Visit incelto.com/ECP to learn more.
Welcome back to the New Retina Radio Journal Club of the Witt-Buckle Society. Let's get into a longer discussion about the paper Dr. Hua summarized in the first part of this episode. So we're talking about a device that got FDA authorization. And before we get into our discussion, I want to tell our listeners the distinct differences between FDA approval and FDA authorization. So an FDA approval requires full regulatory approval from the FDA, confirming the product's safety and efficacy based on rigorous clinical trial data. It's usually applied to things like drugs and biologics, and its scientific rigor is the highest, usually requiring multiple well-controlled clinical trials proving the safety and efficacy, and that takes time. So these trials are typically longer, several years, or maybe multiple phases. FDA authorization is different. It's typically a temporary or limited authorization based on preliminary evidence, and it's often used for medical devices or in emergency situations. The scientific rigor is lower and can be based on limited evidence, or substantial equivalent evidence from existing devices. And that makes this process faster, sometimes only months to maybe a year if the device is similar to an existing one. And we're going to dive into that when we look at the differences that this paper looked at and in the study. And we'll start with visual acuity gains. So I'll recap that at month 13, those treated with photobiomodulation gained about 5.4 letters, while sham gained about 3. Dr. Cai, given that 3-letter gains in the sham group could suggest a placebo effect, do you think the photobiomodulation results are clinically meaningful?
That's a great question. We think about 5 letters as being a line. And so this is a difference between a patient being 20/20 minus 3 versus, 20/25 plus 2. And Dr. Sada brings up a great point that, interestingly, the average visual acuity was a little bit lower than expected for a patient population with dry to early to intermediate dry AMD, being around 20/20/20/40 range rather than 20/25 range, which might have been expected. So there could have been some component of regression to the mean, meaning the patient had a bad day initially on the first initial visit, and then later on at the end point of the trial, they regressed to the mean and improved. And that could explain why there could be a 3-letter gain having a bad day. Clinically meaningful, as retina specialists, we're very happy to see -2 and -3, 20/40 -2 for us is equivalent to 20/40 for many people. There are so many reasons for missing a letter or two: lighting conditions, being in a different room, dry eye, not having the perfect pair of glasses, having some dust on your glasses. There's just so many different reasons to miss 1 or 2 letters that I would say a 2-letter difference is a little bit clinically not as significant.
Mm-hmm. And I'll throw this over to Dr. Hua. About half of the improvements we saw in both groups occurred within the first month. Dr. Hua, do you think this suggests a true treatment effect, or maybe simply a natural, vision and fluctuations?
I think there's so many variables, and on top of that, of everything that Dr. Kai mentioned, on top of the unclear or opacity of the protocol within the trial, I think it's hard to contribute it completely to treatment effect.
I agree. I think, at such a small level here, almost splitting visual hairs here, it's hard to really tease out exactly what's causing some of these changes and when. Now, one of the things we need to look at whenever we have a new therapy on the market is safety, and in this case, potential phototoxicity. So this is a new application for macular degeneration, but in the article, they talk about the treatment of photobiomodulation for myopia, used in China very extensively, although it is stated that the light used in that may exceed that of the limit of a class 1 laser. And we see patients with macular degeneration who have sicker RPEs than the young healthy ones in those studies. And there was a case report that was referenced of a young child who had RPE damage from the photobiomodulation. So Dr. Cai, do you think that that's something we need to be concerned about with our older AMD patients, or is it just kind of the same standard patient population?
This is also a problem that I see often with our complement inhibitors. Our goal for dry to intermediate AMD is to prevent conversion, especially when they're early. Not only, prevent accumulation of drusen and prevent accumulation of geographic atrophy, but the AREDS2 studies, the goal was to prevent conversion into wet AMD. And to see, I think it was 5% versus 1% in the control arm convert to wet AMD is concerning for me, because wet AMD conversion does result in permanent visual decrease. So even though the mean may have some improvement overall, 5 compared to 3 letters, the patients who did convert have a higher chance of having a worse outcome. And so that is something that has to be studied very carefully, because we can't offer a treatment that increases the likelihood of converting, because that ruins the point of any preventative study.
And Dr. Blackerby, with regard to the phototoxicity, I think, the N in this study is so small that the jury's still out, especially in our older patients who don't have has young and robust RPE and who
Mhm.
are pseudophakic probably more frequently, and who knows if, our natural crystalline lens has some kind of protective
Mhm.
effect with the phototoxicity. And so it definitely has to be studied more in terms of the safety of the phototherapy.
I agree. I look forward to future research and studies from this to really see the impact of this in terms of safety and efficacy. So when we dive into, new technology, we're retina surgeons, we love new technology and innovation. Is this something we need to get excited about? So Dr. Cai, is dry AMD a new treatment for that something that is on your horizon, something you've been looking for?
I think it is. And the right type of patient, we've all seen patients who have had lost vision from geographic atrophy in one eye, and they want to do anything that they can to prevent vision loss in their better seeing eye. And it's difficult. I know complement inhibitors have been out, and it's difficult to recommend a an injection every other month because of the burden of the injection, because of the discomfort with the injection, and the potentials for vasculitis and inflammation. It's much easier to recommend something that seemingly less risky, less chance of endophthalmitis. So I do think in some way they're onto the photobiomodulation study is onto something, especially with the drusen decrease. But it may be a matter of dosing, and it may be a matter of which wavelengths to filter out, and it may be a matter of how often that needs to be done. That needs to be addressed. So I am excited for this area, especially for those patients who've lost vision from significant geographic subfoveal atrophy.
And Dr. Hua, what's your main clinical takeaway from the study?
Main clinical takeaway is that the jury's still out. I think we have to wait for more data. I think we have to, wait to see uptake and practicality of applying this in a retina clinic, or, where will patients be receiving this therapy? We also have to see what the reimbursement will look like for this procedure, and if patients will buy into the therapy, and will actually notice a true clinically significant improvement in visual acuity. So I think we'll see, but it's exciting stuff.
I agree. That wraps up our discussion on photobiomodulation for macular degeneration. We explored the study's findings, debated its clinical significance, and examined the broader implications of device authorization versus approval. While photobiomodulation presents an intriguing potential therapy, important questions remain about its long-term efficacy, placebo effects, and real-world applicability. As with any emerging technology, continued research and clinical evaluation will be key to determining its true role in patient care. I thank you both, Dr. Cai and Dr. Hua, for your thoughtful insights and engagement in this discussion. And to our audience, we appreciate you tuning in. Your curiosity and participation make these conversations so valuable. We look forward to exploring more cutting-edge topics in the future. Until next time.